there's a lot of there are a lot of different genetic variants involved in scoliosis and have been implicated in scoliosis. And certainly not just by us. I mean, most of the genetics research on scoliosis has been published worldwide for some time. And the problem is, despite knowing all that information for decades now, very few clinicians have ever really taken that information and put it into practice. And I think, quite honestly, ScoliSmart is one of the few, I don't really know of any others, quite honestly, who have taken the steps that we've taken to try to integrate a lot of that information into what we're doing. And so the purpose of tonight's talk is to kind of say, okay, when we take on a new patient, child or adult, what are sort of the pathways that we're looking at to say, okay, so we're doing this test, and when do we do it? So we're doing this test, when do we do it? What does the combination of these two tests tell us? What does the combination of these two tests tell us? So it allows us to kind of develop a pathway to say what types of things are contributing to that person's scoliosis, whether it be an idiopathic scoliosis, whether it be an adult degenerative scoliosis, I mean, whether it be a neuromuscular scoliosis in some cases. So we're really trying to integrate everything together, because scoliosis, as we've been harping on in the Warriors group for a long time, scoliosis is far more than what the curve is. And there are a lot of contributions to the curve, to the point that the curve is really just the primary symptom of an entire problem. And maybe it's the most obvious symptom, but it's still just a symptom. And so not only do we want to treat that primary symptom, but we want to treat the health aspects that allowed that primary symptom to develop in the first place. So let me jump into it here. So first off, let me grab a different color. Let's go to green or purple here. So first off, depending on the age of the patient that we're going to get here, that will lead us into which testing is important. So for example, when we have a patient that does a phone consult or they consult in the office, for example, we will ask if there's a strong genetic history. You know, does mom have scoliosis? Does dad's mom? Does mom's mom? Does an aunt, uncle? Does anybody in the family have scoliosis? So as soon as we hear that somebody else in the family has it, obviously, of course, the genetic aspect of this already kind of lights up for us. So for example, when we run genetic testing, let me just go into genetics for a second. When we run genetic testing on people, what we're really looking for are the genetic variants that are specific to scoliosis development or scoliosis progression. As an example, a couple of the genetic variants, I should say, that we look for, and of course there are over 25 of these. So one of them is MTHFR, which many people have heard of. It's kind of like the genetic variant du jour, I think, kind of like vitamin D was, 20 years ago, or fish oil 10 years ago, that kind of thing. And another variant, COMT. So let's just take these two into account for a second. There are, like I said, many others. But for example, if I look at these two genetic variants, these genes code for two very specific enzymes. So a lot of people think, okay, what does an enzyme have to do with scoliosis? Well, the idea is MTHFR does a couple of things. First, it allows the conversion of serotonin into melatonin. Secondly, it is responsible for the methylation, or let's call it activation, if you will, of your B vitamins. Specific for what we're talking about, I'm talking about vitamin B6, vitamin B9, and vitamin B12. And just these two functions alone are highly implicated in scoliosis, and I'll give you multiple examples. So first off, obviously melatonin has been well known a long time to be implicated in scoliosis development. And for a long time, one of the things that a lot of researchers try to do is just give people melatonin. And in integrative medicine circles now, one of the things that's really kind of well known with melatonin is the problem is when you give melatonin, which is the end product in its pathway. So for example, melatonin is the very end stage up here in what's called tryptophan pathway. So we have serotonin converts into melatonin. Then up here we have 5-HTP. Then up here we have tryptophan. There's a couple of intermediate steps, but you get the idea. Now, where we see arrows here, back wrong way. Where we see arrows, those arrows are essentially enzymes, okay? What happens, obviously this enzyme is this, methyl tetrahydrofolate reductase. It's an enzyme. It's also here. It activates B6. Well, guess what one of the enzymes is, that activates, converts serotonin into melatonin? B6. So if I don't have MTHFR making enough and activating enough B6, I can't get this part converted. Okay? So, what we find in some cases, as an example, when we find this genetic variant, what we may find is then that person's neurotransmitter ratio is off. And the problem then becomes if, under the conventional wisdom, I might say, okay, well, let me just give them 5-HTP because they're having a problem with serotonin. But the problem is not the lack of 5-HTP in this person's case. The problem is they have a genetic variant that's allowing that neurotransmitter ratio to become problematic. So what you have to do is not intervene at the level of the neurotransmitter, you have to intervene at the level of the genetic variant. And there are specific ways that can be done. For example, with MTHFR, we give the pre-methylated versions of the B vitamins. So for example, the methylated version of B6 is called P5P. B9, which most people know as folic acid. Folic acid is actually the synthetic form of vitamin B9. The methylated form of B9 is simply called methylfolate, or the moniker, just like this, 5-MTHF is the active form of vitamin B9, and for vitamin B12 is methylcobalamin. So what we do is, knowing that this person has this genetic variant, or inefficiency, let's call it, we're giving them the end-stage products that this enzyme would normally be responsible for. Therefore, we're essentially trying to reroute around this genetic variant to minimize its impact on the downstream neurotransmitter activation. That's just one example. Now, let's go to COMT. COMT does also a couple of different things. So first, COMT is responsible for, let me get another color here just to keep it lively, is responsible for the methylation of estrogen. And it's responsible for the activation of dopamine. So again, we have a situation where this COMT enzyme, catechol methyltransferase enzyme, for people who want to know what that means, has an impact on a hormone, estrogen, highly implicated in scoliosis development or progression, and dopamine, a neurotransmitter that, again, not coincidentally, gets converted downstream into our adrenaline hormones, norepinephrine and epinephrine. Or some people refer to them as noradrenaline and adrenaline. So when we have a variant in this pathway, we start to have complications where now the body can't accomplish this. In terms of estrogen, let me just take this bottom part out of the way for a second. In terms of methylating estrogen by itself, when your cells have used a molecule of estrogen, and the most bioavailable hormone or estrogen hormone in the body is called estradiol. It gets converted, once it's been used by a cell, the cell kicks out waste products, which are hydroxyestrogens. And I'm not going to go into the different numbers, but you get the idea. The problem then becomes COMT's function is to attach a methyl group onto this waste product so that your body can eliminate it or excrete it. When this doesn't happen, now we run into a situation where this molecule, which is a waste product, gets recycled back into the body, and the body tries to use it as estrogen. So you run into a situation where you can test people for their blood levels of estradiol and they'll look normal, but yet they're telling you they're having symptoms of estrogen imbalance, estrogen dominance, estrogen ratio problems relative to progesterone, testosterone as examples. And it's not because they actually have excess estrogen, it's because they're recycling this waste product back into the system instead of methylating it and excreting it in the stool, for example. So again, here's the problem with having this estrogen recirculating back into the system. This waste product, although the cells are trying to use it as a full estrogen molecule, the analogy that we could kind of use for our discussion would be like, this molecule would be like E85 gasoline. It doesn't have quite the same octane and the same punch as, say, 92 octane. But it can essentially serve some purposes. So it'll get your car to run, it'll get your cells to do what they need to do, but it's not ideal. And the problem then becomes when you have a molecule being used that's not quite serving all of its intended purposes, what we then tend to run into with specific regard to scoliosis is we run into an estrogen signaling problem. And in particular, we're talking about estrogen signaling relative to the onset of monthly cycles, as well as the calcification of end plates, aka abnormal bone growth or bone signaling. And so when you have estrogen molecules that are kind of working here and there, you now start to get abnormal firing patterns of the downstream estrogen-based signaling pathways, which lead to end plate disruptions, leading to asymmetrical growth of the spine, certain axial joints, for example, the ribs. They know, for example, from a signaling perspective, some of the ribs will grow longer, faster on one side of the body compared to the other. And so these are extremely important. Now, again, we could look at estrogen and might test normal, and maybe it tests a little bit high, but the problem is not really with estrogen. The problem is right here. And so again, we run into a situation where we have to give the person the ability to reroute around this so to minimize this effect. And so, for example, in somebody who has some, like a COMT genetic variant, it's many times beneficial, especially for an adult patient who has hormone change time. So for example, maybe shortly after pregnancy, or more importantly, peri and postmenopause. And the reason being is because, again, in postmenopause, you're not producing that much estrogen anyway, or naturally you're not supposed to be. However, we still find that we still have estrogen signaling problems because a lot of adults accumulate what are called xenoestrogens. And those are basically estrogen mimicking chemicals that we absorb into our body from our environment, our polluted environment. Things like BPA in plastics, or the thermal receipts from a department store or a gas station pump. Those thermal waxy kind of receipts have 100 times more BPA on them than what you would get from drinking out of a plastic bottle, as examples. So xenoestrogens are a big problem in all this too, especially when somebody has this particular enzyme. Not coincidentally, people who have a strong variant in this COMT pathway are predisposed to things like breast cancer. And that's obviously not a coincidence as to why. So what about juvenile scoliosis? Juvenile scoliosis, to me, you have these same genetics. That's a good question, actually. So what about juvenile? Quite honestly, to me, juvenile has a stronger genetic component than adolescent idiopathic scoliosis. Whereas I think adolescent sometimes can have a bigger environmental impact, especially when a child hits puberty and then the curve accelerates out of control. I think in juvenile cases, at least from my observation, excuse me, juvenile cases are more prone to having a lot more of the genetic variants with respect to scoliosis than an adolescent idiopathic case would tend to. And I don't think it's a coincidence that a juvenile idiopathic case is naturally going to be more progressive statistically than an adolescent idiopathic case. So let me give you kind of a real clinical example of intermingling all of these. So let's say a patient comes in, and let's say it's a child, let's say it's a 13-year-old girl, and we do her neurotransmitter panel. And we find kind of one of the, let's say, typical, quote-unquote, neurotransmitter imbalance patterns, where we have low serotonin, we have low histamine, and we have elevated norepinephrine, and maybe we have within normal level of glutamate. Yeah. So, reading this in and of itself might not tell you a whole lot, other than this is low, this is low, this is high, this is normal. However, what this doesn't tell you is why it's abnormal. So as an example, if this is the only test we're doing, one of the typical scenarios would be to give this person something we use called NT support. And this is kind of the classic scoliosis abnormal panel that we would see from which to recommend this. However, there are times when we give them this product, child takes it for say 4 to 6 months, we repeat the value, and all of a sudden it still looks like this. And we say, okay, you've been taking all the right stuff, 5-HTP, you've been taking essentially all the amino acids that are required to convert these and the enzymes required for their conversion, or down regulation as the case may be. And yet it still looks like this. Maybe a few clicks closer towards normal, but still relatively abnormal. The problem then becomes then what we need to run is the genetic panel. So we run the genetic test through 23andMe, a lot of you already have, and come to find out, let's say this person has a couple of things going on. Let's say, as an example, they have a problem with a very specific enzyme pathway called SHMT. They have another genetic variant in, let's go with superoxide dismutase. Another classic one. Finally, maybe we have one FAD. And these are all scoliosis genetic variants, by the way. And these three are all coded genetic variants for certain enzymes that do very particular things. So for example, SHMT is an enzyme that helps your body in the central nervous system utilize histamine correctly. SOD is an enzyme found in the intestinal tract that helps your body absorb the amino acid precursors out of your diet from your digestive tract into your bloodstream. FAD stands for fatty acid desaturase. FAD is an enzyme that helps your body break down fatty, high-fat foods, good or unhealthy fats, coconut, avocado, things like that, omega-3, fish oil, stuff like that, breaks them down into constituent fatty acids that actually help also with the down regulation of norepinephrine. So we might see this pattern, put them on all the right supplements, and the pattern doesn't change. Now we're in a situation where like, okay, we have this, now what? So as an example, we now have to address and intervene with this panel at the level of the genetic variant, not at the level of the panel. And that's why it's important to really kind of have both pieces of this information So we know how these are interacting with one another. Otherwise, this child's going to be taking NT support forever and ever and ever. And sure, ScoliSmart Labs will make money, but the child doesn't get any help, and that's the point. It's better to have more complete testing done to get a very encompassing picture of that child's physiology to know where we need to intervene. Because the idea is when we find out where we can intervene, in a lot of cases, we might find that 1 or 2 genetic variants may be responsible for 3 or 4 different neurotransmitter imbalances or hormone imbalances or bone density problems. And by intervening at those 1 or 2, it now saves us from that child having to take 4 or 5 things, as an example. And they get better help because now we're getting to the kind of the core of the issue. I'll give you another case. We come in and we have, now let's say it's an adult patient. So adult patient comes in and we, because they are postmenopausal, we do a bone, let's say, bone metabolism test or bone turnover test, which is a urine test that we do to check for some very specific protein metabolites. Specifically, you can check N-telepeptide, and this is probably the most common one that you'll see. And the reason why we like this test is because it also happens to be the same test that a lot of doctors use who are monitoring patients who are taking bone density drugs. Because this is the metabolite they're trying to see if they can lower in the urine as a result of taking the bone density drug. So we just use the same test, we're just typically doing a different intervention. So N-telepeptide is what we test. Now, to give you an idea, a normal N-telepeptide test for an adult patient should be about 0 to 20. Okay? So let's say this patient's test result comes back and it's 77. Hugely big number. Bigly huge. I don't know, whatever President Trump says. 77, big number, right? So the problem is it's way too high. So now the question becomes, why is it high? So we have options here. There are options testing-wise and options treatment-wise right away. The nice thing with the bone turnover tests is that no matter what we do from a treatment standpoint, we can repeat this test in as quickly as 90 days to see if this result changes as a result of whatever intervention was used. That way, unlike a bone density scan, we don't have to wait 2 years in most cases to get another bone density scan to see if it helped or not. So if this is not working, whatever treatment we decided, a lot of people, for example, just take calcium and vitamin D. They repeat the test, it's not working. So now we can switch that at a much sooner interval than having to wait 2 years and figure out, well, I just wasted 2 years worth of time and money on a treatment that was not helping. So we find out, we put this person on product X, whatever that is. And 90 days later, it's only 76. So it didn't really help much, okay? So now the question becomes, why is the product, which normally has a pretty good track record, not helping this improve? So if we give people the right things that would normally help them make bone, but they're not making more bone or improving their bone turnover, then we have to look at, do they have a genetic inability to use those nutrients to make new bone, which would be the genetic testing, or do they have a hormone problem, which again is also a very viable option because, again, this patient is postmenopausal. So, of course, they're going to have lower levels of hormones. So it's not a stretch to say that maybe this person is not producing the correct amount of estrogen or too little, or maybe her estrogen ratio is out of balance compared to her progesterone and or testosterone levels. It can be any of those things. And so then the next question is, okay, we should test. Because, again, at the end of the day, our goal is to figure out what is the most upstream cause as to why this is 77 and not 0 to 20. Okay? Now, some people might say, okay, all of this is hunky-dory. But what in the world does this have to do with scoliosis? Well, here's the problem. Let's say we have that same patient. Patient came in because they saw me on Sister Wives and they want an activity suit. Okay? So they come in and they got a curve that looks like this. And just for speed of conversation, these are all vertebrae. Terrible artwork, I apologize. So they have a curve that looks like this. Now, what will happen is if we know that this person's N-telepeptide score is 77, she's losing bone density. The problem is she's going to lose bone density on the inside portion of the curve of these vertebrae faster compared to the outside. So as a result, if we allow this 77 to continue unchecked and not fix it, or at the very least stop continued bone loss, it doesn't really matter what therapy this person does, it's going to have a lesser chance of producing a long-term outcome because this is going to continue happening as long as this looks like this. So I don't want to give a person an activity suit who has this value unless we're also taking the steps necessary to address this value. Because whatever gain they get from the activity suit 6 months later, or a year later, or 3 years later, or 5 years later, is not going to have a chance of lasting as well if they're going to continue to lose bone density on the inside of this curve, which is just going to allow this curve to continue to collapse over the course of time as they continue to lose bone density on the inside of it. So really my investigation has to become, okay, we did our urine test. We know that there's a bone turnover problem. Now, is this a nutrient intake problem? And there are only 3 places this is going to come from. It could be that. It could be a genetic inability to utilize those nutrients. Or 3, it's a hormone problem. Now, here's the other part. A lot of patients don't read medical textbooks. So guess what? Every patient has the right to have more than one of these things wrong with them. So very often it's not just one of them. They might have 2 or all of them be out of whack. And so again, if this person has aspects of all of this, we now have to go through dietary or supplemental changes. We have to go through genetic identifications and enzyme or amino acid therapies depending on the genetic variant we may find. And then finally hormones. And that might be hormone precursors or whatever else, or maybe even some type of bioidentical hormone replacement if the need arises. Might be all of those. We don't know until we test. And so the idea is every scoliosis patient really needs to have a lot of this testing done if they want to maximize the benefit of whatever exercise therapy they're doing. I don't care if there are warriors who have never stepped foot in a ScolioSmart clinic and they're just doing yoga for scoliosis at home, or they're just doing some routine that a personal trainer at a gym put together for them to try to help their curve. If you're not addressing these metabolic, genetic, and hormonal factors that help the scoliosis in the first place, help to cause it in the first place, or allowed it to get as severe as it presently has become, no therapy is going to produce any type of it and has no hope of producing any type of lasting effect. Now, the neurotransmitter panel we run, as I already wrote up here, serotonin, glutamate, norepinephrine, and histamine. Now, for example, and I'll do this visually so it's easier for people who are watching this later and don't have sound, but we'll say this box represents the normal pediatric or adolescent ranges of these neurotransmitters. What we are finding is that the majority of kids with idiopathic scoliosis are 1 standard deviation outside of normal. Like I mentioned before, serotonin is usually here. Glutamate is normal or at the high end of normal, usually somewhere in here. Norepinephrine is usually out here, and histamine down here. So we run into this low, low, high, sometimes high type of a scenario. What we have found is that there is a second or 2 standard deviations. So in children who are out here, 2 standard deviations here, here, or way out here above in their norepinephrine level, these are the children who are more likely to go on to have surgery. So what we're molding right now and what we're throwing around is the opportunity not just to use the neurotransmitter panel to test for these neurotransmitter imbalances, but to actually use this test in concert with the genetic 23andMe testing to see and predict what is going to be the lasting benefit achieved in a child who does ScoliSmart boot camp, does everything we tell them. But the problem might be that if they're sitting way out here, even if they're 100% compliant with what we tell them to do at home, they may still be one of the 13% of kids statistically who fail ScoliSmart boot camp therapy. So what I would like to do is use this kind of testing to try to identify that 13% of our patient population so that we can get them right to the correct therapy as soon as possible. And now we might be able to get a Dr. Lahner, a Dr. Betts, a Dr. Hornschmeyer, these kind of doctors who do tethering, which is obviously the surgery that we prefer kids have, if they have to have it. We can get those doctors in the loop faster so that those kids can be identified and worked with quicker so they're not trying to tether a 70-degree curve. Maybe they're still able to tether a 40 or a 45 or a 50 as it's happening, not waiting until they've already failed treatment and then have to refer them out. So this test not only gives us health status, but also the idea is eventually to make it predictive. And that's a huge benefit to us. The genetic testing again, along that same theme, we basically have around 28 genetic variants that we look at directly involved with scoliosis development. So what we're doing is using the same 23andMe test people already have, running it through a different software program that will measure these genetic variants, and the higher the number of these genetic variants they have, the more likely they are, A, to have a progressive form of scoliosis, but we're honing this information down to say, what if we start doing this test on a 5-year-old who doesn't have any sign of scoliosis yet? And if we can identify these and prevent it, then to us that's the real game changer, and that's what will ultimately cure this problem, is preventing it altogether. You don't have to be a ScoliSmart patient to get to 23andMe. So anybody can get to 23andMe, of course. The information is not the issue. The information is in the raw data file. We then take that raw data file that you get from 23andMe, and we run it through our own software program that we have a license that we pay for to run your DNA or your child's DNA. And it spits out a report for us. Literally, it's about 40 pages long or so, and it has all these genetic variants that we're looking for. When you go on to 23andMe, there are two tiers of testing. There's a $99 version, and I think it's $199. You still get the raw DNA file no matter which test you buy, so I just tell people to always buy the cheaper one. It gets kind of confusing if you're not used to it, because they kind of market it as if you're only going to learn what your ancestry is if you buy the cheaper test. But you still get to download that same raw DNA file either way, and that's all we need to run our analysis. So we have people schedule a lot, people who I have never seen, people none of the four of us have ever seen, to schedule to do kind of a phone review of their report if they want to. There are some people who just want the report, and we can run that report for them and identify the genetics involved. We're actually revamping the ScoliSmart Labs website right now to have it all done electronically. So for example, somebody can go in, order the 23andMe kit, or pretty soon order it right through our website or a different version that will provide the same raw data file. And then at that point in time, they can log into their account on ScoliSmart Labs and retrieve their result, their report. And then at that point, it will automatically have the recommendations from ScoliSmart Labs on their particular genetic variants, what we would consider as far as follow-up testing perhaps, or even for recommended treatments per se, to minimize the impact of those genetic variants. I understand there's some hesitancy with the 23andMe testing because, again, they have access to your DNA, and they're not afraid to sell that information for money. So unfortunately, you have to sign away your permission for them to do that, unfortunately. But I have people that, to protect their children, will use fake names, which is fine, as long as they tell me, what their fake name is so that we know how to run the report. But what I really like about this testing is that this is who you are. This is who your child is, and that's not going to ever change. And so we have older teens right now whose parents are running it for them, not even for the particular child. You know, what they're doing is saying, okay, I know if my child has this genetic variant, then there's a reasonable chance that someday her son or daughter may also have that genetic variant. So, you know, by 2018 standards, we have a certain amount of information, but just imagine if you have a raw data file already, what we're going to be able to do with that raw data file, even in, say, 3 to 5 years from now. I mean, the information on this stuff is coming out now month by month by month. And especially with regard to scoliosis, the way, you know, we've been collaborating with some people overseas and things on really identifying some of these and knowing and learning what to do about them. One of the biggest troubles early on is saying, okay, so we have this genetic variant, and we know it's involved with scoliosis, but how in the heck do you do anything to make it less impactful? And really, that's kind of still the biggest challenge in a lot of ways, because there are a lot of genetic variants kind of like, well, you have this genetic variant, you know, tough luck. And, you know, I don't accept that. And so a lot of these genetic variants that we're looking at are things that we can handle or treat or minimize from a functional medicine perspective. And that's really kind of the unique marriage that we have here from ScoliSmart clinics and ScoliSmart labs.